Good morning, everyone.
Good morning.
Thank you for joining us this morning. I'm Dina Ladd, the Executive Director for Missouri Cures. And for those of you who aren't familiar with our organization, the Missouri Cures Education Foundation, we go around the state providing information and educating people on the importance of medical research, in particular stem cell research. We have a 2012 speaker series. This is our last presentation this year. We're thrilled to have Dr. Csete. We actually are in the planning stages of our 2013 speaker series. So make sure you go to our website. I hope everyone gave their email address upstairs. Okay, and we'll let you know about presentations coming up. I'd like to thank the Washington University School of Medicine Biological Therapeutics Center for co-sponsoring this event with us this morning. Is Dr. Curiel here? Did he make it? Okay. I think he is maybe stuck in traffic this morning, but we really appreciate their support on sponsoring this event. I'd like to thank Representative Jill Shoup, right here. Jill really helped promote the event and get the word out, and we appreciate that. And we also have Representative Kirkton here, right here. Thank you. Dr. Danforth is joining us this morning. And then I'd also like to introduce Margaret Tollerton as our outreach director, right over here. I think she maybe greeted many of you. Debbie Davis is our office manager. So we're a small organization, but we do get around the state. Margaret goes out and talks to AARP groups, Kiwanis, Rotaries. If you have an organization that you would like us to do a presentation at, we'd love to come and speak to your group. So we're basically all about educating people and providing information about the importance of medical research here in the state, in particular stem cell research. So, and I would encourage you to go to our website. We update it. We put a lot of the recent advances on there. You can always contact us if you have any questions, but as I said, our speaker series is really a highlight of what we do. So we'll move on to the program. We're thrilled to have Dr. Marie Csete with us this morning. She is the Director for Cellular Therapy and Regenerative Medicine at AABB, formerly known as the American Association of Blood Banks. Before that, she's also a member of the adjunct faculty at University of California, San Diego. She is the former Chief Scientific Officer at the California Institute for Regenerative Medicine, and before that she was at Emory. So please help me welcome Dr. Marie Csete. Thank you.
Well, I'm really impressed that you all got up in the dark to come here to this beautiful facility, and I thank you for coming. So I'm going to tell you a story of where we are, to give you a snapshot about where we are in stem cell biology. And we're at this incredibly fragile point where there are some remarkable successes that I will tell you about in the clinic, in humans already. But it's a baby, and its mind is developing, and its mind is most plastic now. And this is a fragile growth process, and the importance of keeping the support and focusing our support on ways that take advantage of these early successes is just absolutely critical. So I'm trying to both inspire you by the successes that have happened really against all odds in the last 10 years in stem cell biology, and also to challenge you to go out and be an advocate for this research, which really will change the face of medicine. So this is a slide that I think is essential for thinking about stem cell research and the state of affairs as a child. It really will take a village to move this along. The development of stem cell therapies is, by its nature, a public-private partnership and takes so many different domain experts, from the discovery research through understanding disease models in animals, funding, the handoff of discovery research from academic labs to manufacturing industries where the cells can be produced, and the development of clinical trials and finding the right patient for the right cell. And this has all been slowed down by the obvious political issues that have gone on, and Missourians know this better than anyone. But it's also been slowed down some by the problems in academics with proprietary issues and spinning out companies and fame and fortune, so that people don't collaborate and share their data as much as they should. And I'll give you a story about that as well. So remember that it takes a village, and I'll now walk you through some of the members. We have our cultural challenges, and Dina asked me last night to speak about my experience as an advocate and a researcher in stem cell biology in Georgia when I was a professor at Emory. I had opened the Human Embryonic Stem Cell Core Facility for Emory and Georgia Tech so that the scientists, the great scientists at both institutions, could use human embryonic stem cells in their research but not have to go through the trouble of learning how to handle them themselves. They could come to our core facility and we could do the work for them. That was announced in the newspaper, and the next day I received a call from my state senator who represented the Emory area and he said, "I don't know who you are, but you better get to the State House right away or you're going to jail." And so the legislature had tried to put through a bill that would have made working on human embryonic stem cells, and we were working on NIH registry lines, nothing unusual, punishable by jail time. And it was a 2-year, very public battle that had a lesson for me that was just remarkable. In the end, this bill did not pass. But it didn't pass because we went out and educated the public, and scientists have not done that enough. And when you actually explain to the public who said they were against stem cell research what it is you were doing in your lab, all of a sudden, the polls showed that this was research that the citizens of Georgia, and not just in Atlanta, thought was important to move forward. So we still have these needs to be ever vigilant. There is yet another case that may be accepted by the Supreme Court that would bring down any funding at the federal level for human embryonic stem cell research. It was just introduced 2 weeks ago. So I'm going to skip it. So where are we? In some ways, this industry has grown from nothing to quite dramatic. And recently, I was at a congress where Greg Bonfiglio, who is a venture capital guy, who scours this market, put these statistics together. So regenerative medicine industry is now a $1.6 billion industry, which is substantial, but growing fast. And if you go to the clinical trials registry, you'll see that there are over 4,000 clinical trials, this is humans, related to regenerative medicine. A lot of them have to do with cord blood, that's what CB is there. And a lot of them about 100 are late phase, so getting close to market. That's really an enormous success. And I did my own little search yesterday where I looked in the National Library of Medicine, PubMed, and crossed stem cells with heart attack. And I found in the last very few years over 2,500 papers, and there's a very large wasp on the microphone here. Yeah. So if I look jumpy, put it down. Okay. Thank you, Tina. So this has been a very active space, stem cells for heart disease. And I'm going to tell you this as a not success story, as far as I'm concerned. So there are now over 300 clinical trials active in this space. With 5,000 papers published, we should know more about this than we do. So what's happened in this community? Cardiologists have put all of these various kinds of stem cells that you see on the left-hand side into patients at various times after they've had a heart attack in various places. This picture up here shows a common approach to putting the cells right into the coronary artery, a very aggressive approach. Some of them are being put in directly into the heart at the time of heart surgery. Some of them are going IVs. It's just anything you can think of in any dose at any time related to the acute heart attack. And as a consequence of that, there are so many variables in these papers, you can't make a conclusion about what is going on here. And that is really, to me, a fault of the cardiology community for not cooperating with each other. And again, there's money and fame and academic promotion involved, reasons that are good, but have really slowed down what we know about this field. So after thousands of studies, all we know is that on average, the effect that you get is pretty small. It's transient. Some patients may have been significantly helped. Some patients unnecessarily had their wallets stripped of thousands of dollars, and they weren't hurt, but they probably weren't helped. So the other problem, I think, is that there's no apparent willingness to pull the plug on these cul-de-sacs that you walk down when you realize that they're not optimal. So with all of those kinds of different stem cells that have been given, the way that the patients were followed was usually to look at how hard their heart squeezed on an echocardiogram, and they would get a 3 or 4% increase probably by having the cells. But there was no true regeneration until true cardiac stem cells were discovered, and these cells appear to be restoring scarred heart into actual functional muscle. So this required the discovery, based on animal work, of going into the heart of human patients with a catheter, taking a biopsy, expanding these cells, and giving them back to patients. And now these cells are in clinical trials. And a lot of this other work will probably be dwarfed as the true cardiac stem cells enter the clinic. So we were slowed by the cultural phenomenon of science in this area. I think there's been incredible success in understanding the role stem cells will play generally by looking at what's happened in the eye. So there's lots of good reasons why the eye is the perfect place to really test out what stem cells can do. Unlike putting stem cells into the brain, if you put them into the eye, you can see them. You also don't need a huge number of cells to treat a disease of the eye because it's a small organ. That makes the manufacturing issues much easier. Also, this is an area, eye diseases, where gene therapy has had remarkable successes. And down the road, a lot of the stem cell therapies may well be combined with gene therapy approached. You don't need big-time systemic immunosuppression if you put cells into the eye because it's a relatively privileged site from the attack of the immune system. And also, it turns out that making the kind of cell that you might want to replace in macular degeneration, retinal pigment epithelial cells, is pretty easy in the lab. You don't have to go through a lot of machinations to get to a pure population of these cells from human embryonic stem cells. And if worse comes to worse, and you're treating someone who is essentially blind, and something terrible were to happen, like the ophthalmologist would see a tumor in the eye could come out without losing the patient's life. There's also a huge need for stem cells in this area. So this is a picture of what someone with macular degeneration would see, and that's the most common cause of low vision in people my age and older. It's a very common disease. So, what's going on? This is a place where people are talking to each other better than the cardiologists talk to each other, although there's still a lot of competition. And as I said, there's lots of need. In addition to the kind of macular degeneration that you see here, there's diabetic retinopathy, inherited diseases that cause blindness, again, macular degeneration. So there's been a lot of movement in this space. And you can see, this is a cross-section of the eye, and these are just various layers of the eye, the outer nuclear layer, inner nuclear layer. In an animal with degeneration of those cells, this eye was treated, and you can just see that there's cells there that there aren't in the untreated eye. So there's remarkable clinical data to support entry into the field. And to me, this is great success. But again, we're seeing every kind of stem cell that you can think of, including human embryonic stem cells, now generating retinal pigment epithelial cells, going into patients' eyes. This therapy will be the first use of induced pluripotent stem cells in the clinic to treat macular degeneration. So that was just announced in Kyoto. The Nobel Prize was given a few weeks ago to Shinya Yamanaka and John Gurdon. Shinya Yamanaka determined the cues that could take any cell in your body and revert it to a human embryonic stem cell-like state, where it could then be used to generate other kinds of cells. And so these are called iPS cells. And less than 10 years after their discovery, the University of Kyoto has announced their intent to enter clinical trials for macular degeneration based on iPS cells. That's a remarkably short timeline for such a complicated process. So I think this is a great success. But here, the reality of science comes through. So I showed you that picture of the eye in cross-section where you replaced necessary cells with a stem cell transplant. But the problem is that the animal models, and this is true for just about any disease, do not recapitulate the disease environment of humans. So this is a list here of some of the bad actors that cause damage in macular degeneration. And there's no animal model that has all of those bad actors. So we have some that have too much oxidative stress, but they don't have these plaques that appear in the eye. Some that have vascular, some animals that have leaky capillaries. It's not good to bleed into your eye. Some that have inflammation, but not one animal recapitulates the whole process. And so we're left in this position of saying that we've cured macular degeneration in a mouse and not really being able to predict what will happen in the much dirtier disease environment, the much more heterogeneous disease environment of us outbred humans. So this is a real challenge. Nonetheless, I think that this is one of the great success stories. So this is a picture of a pure field of retinal pigment epithelial cells. The pigment is the black. The cells that are likely to, if transplanted, cure macular degeneration. And these were generated from pluripotent stem cells that can be generated from the induced pluripotent stem cells, from human embryonic stem cells, and other kinds of pluripotent stem cells quite easily. And the purity itself is, again, a remarkable success story. In my mind, the best stem cell story that's been out in clinical practice now for a decade that is really curative for a horrible disease is something that's completely under the radar. These are adult stem cells of the cornea called limbal stem cells. And this is something that at AABB we are working on with our colleagues in the ophthalmology societies. So patients who have a chemical or thermal burn to their eye lose their vision because the cornea becomes opaque and you can't see through it. And they also have terrible pain. So remember when you just scratch your eye a little bit, how awful that is? Can you imagine that whole surface being raw? It's a horrible, horrible disease. Well, it turns out that in this little corner of your eye, a place called the limbus, you have stem cells that shoot out the surface of the cornea continuously for your whole life. And if you have an injury that is one-sided, the ophthalmologist can biopsy your other eye, grow the cells up in the laboratory, and transplant the graft back. And this is a remarkably successful therapy that not only restores vision, but also takes the pain away. And nobody knows about it. This is true success. It can also be done from another donor if the injury is bilateral, and then there is some immunosuppression required. Well, as you can imagine, this is not a high-volume treatment because luckily we have OSHA and we don't have a lot of industrial accidents. But in places like India where assaults with lye, especially on women, is fairly common, this is a common procedure, and the innovation in this area is all coming from India as well as from Europe. So again, if you want to point to why it is that it's important to work on stem cells, this is the one you want to point to. The other successes come in the area of tissue engineering, and this is a big surprise. So I'm showing you pictures of a very elaborate procedure that was done to replace a patient's trachea. So another patient's, a donor trachea, was implanted into the arm of the future recipient because the surgeons and everyone predicted that you would have to vascularize this structure, give it a blood supply before you transplanted it in order to assure success. And so these were some of the first allogeneic tracheas. But with experience led by Paolo Maccarini, a surgeon from Italy who's now at the Karolinska Institute in Sweden, he developed completely tissue-engineered tracheas, not from another human donor. At first, seeded them with the recipient's cells and then transplanted after the cells had grown all over. But they were finding that the right engineered trachea, absent of cells, called in all the cells, and they didn't need to use any stem cells, any differentiated cells, anything. And this really points to the increasing knowledge of how the mechanical cues to cells really can be a very important switch-like structure in regeneration. So now Dr. Maccarini is traveling the world teaching people how to build these engineered tracheas and transplant them. This is a great story. But it's not a stem cell story. On the other hand, we wouldn't know it unless people were pushing with the promise of stem cell therapies to get the constructs into patients so that we could learn what it is that we needed, what was essential for regeneration. And we're seeing also the engineers developing really clever tools to instruct the cells. And I'm a fan of Karen Chrisman, a young engineer at UCSD, who takes organs and strips them of their cells, and then makes a matrix powder of the proteins that are normally outside of the cells, that normally give the cells cues from outside. And she makes them into what she calls tunable hydrogels that can have surface tensions of various degrees. And she then determines the behavior of cells based on just the surface tension. These gels are so powerful that when injected into the heart of pigs in a heart attack model, they do just as well as stem cell injections, because again, they're calling in the endogenous response. And ultimately, the power is going to be combining these kinds of technologies with the cells to really synergize the actions of both. Again, a remarkable success story. And this is just from Karen's work showing that after injection of her hydrogel into the heart, these green cells are the cells that you want to call in for repair. And the treated animals have a lot of them, and the untreated animals have only a few. So in my clinical life, I've worked for the last 25 years as an anesthesiologist and intensive care doctor on a liver transplant service. And the major events and successes happening in stem cell biology remind me so much of where we were in clinical transplantation 25 years ago. And it's been people who are willing to take calculated risks who are also driving this field forward. And I want to tell you the story of two of them, again, as a great success story. So Steve Badylak at Pittsburgh was funded by the Department of Defense to try to grow digits for soldiers who came home with their fingers blown off. And he used, again, only a protein matrix that he isolated from human gut, put on the matrix on the end of the wound stub, and was able to grow small bits of fingers with all of their components. Again, calling in your body's normal response. That doesn't sound like a lot, it doesn't look like a lot, but if you can have a hook instead of no hook, that's a real activity of daily living advantage. A similar story didn't lead to quite the success. This is an engineered bladder made by Tony Atala at Wake Forest, where he constructed a bladder out of collagen and then seeded it with the patient's own cells. These bladders were implanted into patients, and about 6 patients who did not have functional bladders. In phase 1, things looked good. It failed in phase 2. And the reason it failed is that no one in the company that was developing this could repeat what Dr. Atala had done. And this is a very important message. People have to talk to each other. People have to have standard operating procedures that are transferable. I think the people who have driven the first use of human embryonic stem cells in patients are also heroes. Again, there's fits and starts here. As a lot of you know, Geron Corporation went into, I think, 5 patients with embryonic stem cell derived oligodendrocytes. These are the cells that coat neurons with myelin. And they developed instrumentation for the surgeons to put them specifically in one place in the spinal cord in patients who had spinal cord injury. The patients, we don't know outcomes from these patients. The company decided to abandon its stem cell programs. It's now being purchased by another company that hopefully will move this forward. It was a 10-year heroic effort of enormous amounts of research. There were more than 20,000 animal transplants done to prepare for that first ever human embryonic stem cell trial. Similarly, ACT, another California company, is going ahead with the stem cells that I showed you for macular degeneration. This takes courage. And I'll tell you one other lovely story of Doris Taylor from Minnesota. Those are her hands here, and she's holding the skeleton with no cells of a rat heart that she then seeded with cells and put back and made a functioning heart from it. So again, mechanical cues. And this is something that's going to surprise stem cell biology. I'm going to skip this. We talked about the iPS cells, the Nobel Prize being a major landmark, and this has really changed the way that we look at biology and the way that we look at developing therapies. So stem cell biology now has a reach into diseases we never thought we'd have, because you can make iPS cells from a patient with a disease and then try to recapitulate that disease in a dish and use that disease in a dish to screen for drugs that change the pathology. And this is already a huge advantage for pharmaceutical companies who otherwise would have to do these experiments only in animal models, and remember, animal models that are very flawed in not reflecting the human situation. So, great success, but some surprising lessons that the cells are not necessarily needed. Ultimately, the power of stem cell biology is going to have to capture the power of engineering, and the two together, I think, is where the field is going. We know more about some diseases that the pathologists couldn't tell us much about because we can make these disease models in a dish. That's a remarkable story. And we've also learned that the ability to transition cells by manipulating not the sequence, but the control elements of the genome are much more plastic than we thought. Cells are much more reprogrammable, and that's an important lesson. So the final success story, before I say where it is that the baby is and what we need to do to keep this path going, is of course bone marrow transplantation. So bone marrow transplantation is blood stem cell transplantation. It's been going on for 50 years. Increasingly, surgeons are not having to go with a big needle into your bone marrow. There's drugs that mobilize the marrow stem cells into the peripheral blood so that they can be collected that way. And increasingly, cord blood stem cells are replacing bone marrow transplants. This is a place where thousands and thousands of people have been cured of cancer, particularly children. And interestingly now, the fastest growing area of bone marrow transplantation is for autologous bone marrow transplantation to knock back cancers like multiple myeloma in patients who are older, who would never have been eligible for transplants before. Unfortunately, bone marrow transplantation still has a very high mortality associated with it, and so the research focus is on how to make cord blood or other hematopoietic stem cells engraft faster. Because in order to make space for the bone marrow transplant, your bone marrow is wiped out by radiation and chemotherapy, and so during that time you have no immune system and are very susceptible to infection. And unfortunately for patients who are about 45 years old, the overall mortality is probably about 40%. So the emphasis on research now is how to shorten that time to engraftment. And here's another story that tells you about the importance of communication standards and good record keeping. A postdoc in Len Zahn's lab at Harvard in 2005, working in zebrafish, found evidence that a molecule called prostaglandin E2, PGE2, caused blood stem cells to move around. She could call them in using this. And so they did some knocking on the door of the Harvard Stem Cell Institute and said, hey, do you think you guys can use this clinically? And in collaboration with the incredible group there at Harvard, they developed a stable form of this molecule, treated cord blood with the molecule before it was transplanted into mice, and showed a major shortening in that danger period time to engraftment. They did the studies in monkeys at the NIH in anticipation of moving this to a clinical trial. And they went to the first clinical trial in 2009, 4 years from fish to human trials. And the clinical trial didn't work. So why would something that works in mouse and apes not work in the human setting? Well, the scientists looked at the residual cells that hadn't been transplanted and showed that the protein wasn't working in those cells. And it turns out that they went back and looked at the lab notebooks of the scientists at Harvard versus the scientists in the company that were preparing the cells for transplant, and there was a temperature difference in the handling of the protein between the two. So they repeated all the animal work with the temperature difference preserving the protein activity, went back into clinical trials again this year, and now are seeing a signal. So the importance of standardization is something that I want to emphasize, because that's where AABB is stepping in. So how do we keep this remarkable momentum going? There's so much promise. We haven't quite gotten to the volume of cures that are possible with these therapies. It's really important for us to not reinvent the wheel, to talk to the solid organ transplant surgeons and physicians who have thought about the immune response to cells for a long time, have thought about how you preserve organs for transplantation, how you ethically approach donors. And there's very little crosstalk between these communities. We want to start funding these common bottleneck problems, the problems that go across all of stem cell biology, and we want to start talking to each other. So it's important for the agencies, for advocates, to make sure that the right disciplines are talking to the right disciplines. If the engineers don't talk to the biologists, we're not going to get very far. And it's also important that we think about outcomes databases that really allow us to get information from clinical trials in real time, rather than waiting for someone to publish a paper of just their series from their one center. And finally, the NIH is funding these kinds of things. And importantly, I've told you a couple of stories: the bladder, the blood, where standardization in the methodology would have prevented the stops in the road. And so what we are doing at AABB, we think, crosses all of these boundaries. AABB has been standardizing and accrediting blood banks and transfusion services since just after World War II, recently went on to bone marrow transplants and cord bloods, and now took this courageous effort to take on all of cellular therapies. And we are developing quality systems that will take therapy from the donor through production through the recipient, that really assure that the scientists are talking to each other, documenting what they do, and can trace errors and unusual results. And we hope that we can get our colleagues outside of the blood community to become members of AABB and take advantage of our accreditation system. The goal is safe product, safe donor, safe recipient. And we are the only accreditation organization in the US that's actually recognized by the people who recognize excellence in quality in healthcare. And that original slide that I showed you with all of that expertise that goes into the development of a successful stem cell therapy, standards and quality systems go through every domain of that road. And so it's time to realize that it's not just the discovery scientists, the clinical scientists, and the FDA. We have to have quality systems as part of this development process as well. I thank you very much. So the best part is questions, and I'd love some. Yes.
Yes. You talked about the stem cells with cancer, and I saw at the end with immunohematology. What about autoimmune diseases?
Yeah, so autoimmune diseases do have some clinical trials going on with a very special kind of stem cell called mesenchymal stem cell. And these cells actually turn down the immune system. So I know of trials in lupus, in inflammatory bowel disease, in some arthritis diseases that have an autoimmune component. And the interesting thing about these cells is that the immune system ignores them, even if they come from another person. So this is a very active space. It's also a space where these mesenchymal stem cells these are the kinds of cells that are being injected into Peyton Manning and Governor Perry, and without real data to support that kind of use. But there are good quality clinical trials going on for autoimmune disease using those cells. Yeah.
You touched on possible therapies for ALS, astrocytes, I think it was, with ALS models. Do you have any more information that you could touch on for ALS therapies that are in development, or?
Yeah, so this is a very difficult disease, as you know. So there is a trial ongoing now at Emory. It's a collaboration between the neurosurgeon there, Nick Boulis, and Clive Svensson's group at Cedars-Sinai in Los Angeles, injecting neural stem cells at multiple levels into the spinal cord in ALS patients. The results are just now starting to be developed. There are some other approaches, but what's been discouraging in the animal model work is that it's looking as if you're going to have a combined skeletal muscle regeneration approach as well as the peripheral neuron approach. It may be a dual stem cell therapy. But these initial trials, which are very aggressive in terms of the stem cell number and stem cell placement for ALS, will give us a window into what the neural stem cells can do alone. Yes?
Trying to connect two issues. You mentioned funding problems, of course, always exist. And the report from the Karolinska Institute on the generation of the trachea for this one patient indicated that the cost was $500,000. The development doctor who was traveling the world to teach this technique, where might we see the cost going of that? Because $500,000 is kind of prohibitive.
Yeah.
So, I've got a friend in St. Charles who could use it. He's been very active in this area, talking about smoking issues because he lost his voice smoking.
Right.
And talks with a device.
Yeah, so the costs have come down dramatically, and that quote really included all of the research development that went into that first trachea, not the actual cost of patient care. But now that the trachea does not require cells, does not require a long culture period in a sterile environment, and can be developed in a small bioreactor, the costs will be very, very, very low compared to the benefit. So that's very important. The scale-up issues for making a big bank of cells, just like you'd make a big vat of drugs for stem cell therapies, are still very prohibitive because the growth factors that we use to drive the growth of the cells are very, very expensive. And so people are working around that by trying to develop small molecules that can be synthesized to replace the growth factors, and that's a very active area in chemical biology right now. But no question about the fact that these are going to be expensive therapies, and I think we should anticipate that they'll be as expensive as the equivalent of a solid organ transplant would be for treating the same disease.
Yeah, you spoke about the problems with communication and standardization. Do you think that that's more prevalent in the U.S. than in other countries? Because you spoke about India, and do you think it's across the board?
No, I think it's the culture of scientists worldwide. Yeah, I can't think of an example of a country that, well, I mean, the countries that have health databases embedded into their public health system are at a distinct advantage. So, for example, when you're in ICU medicine, Canada's ICU system is completely archived in a way that allows investigators to go back and do retrospective or prospective studies much more easily than in the U.S. So it's a larger culture of science and medicine, I think, that has to be attacked before we just fix the stem cell biologists. Anybody else? Yes.
I'm just wondering, since communication is a great roadblock in your research and development, is anything being done about changing the patent laws to allow this to happen?
Oh, this is so messy. The answer is no. And for good reasons, a lot of the beautiful work inside of companies is not published because otherwise they lose their intellectual property. But the patent space is very, very fluid, and I don't understand it at all. But certainly things are not being made any easier in terms of protecting intellectual property in this area. Yeah.
The thing is that it's not only true in your area of research, but all technology.
Right.
Experience.
Yeah. I mean, a lot of people blame the FDA for slowing things down, and I really have the opposite feeling. I mean, the FDA's first mantra is patient safety, and they are so undermanned for the job that they have to do, and they have to make these really tough decisions. When is something safe enough to go into patients? You know, big black box. So I think that they've actually been very helpful in the stem cell space, but the patent issue is in the commercial space has been really a problem. Yeah.
What about Alzheimer's, Parkinson's, adult versus embryonic research?
Yeah, these are active areas. And I don't think that the adult versus embryonic story has played itself out. You can get to functional dopaminergic neurons either way. In the end, if that turned out to be the right therapy for this disease, which I'm suspecting alone, it's not going to be. There may be a financial advantage to starting with embryonic stem cells just because you could generate from those a huge lot that wouldn't have to be characterized. And if you start working with adult stem cells, they have a limited kind of growth phase so that you'd have to characterize many, many lots to treat many patients. You know, there were active stem cell trials, controlled stem cell trials back 15 years ago for Parkinson's disease that showed that we just don't understand how to dose cells. So some patients were undertreated and had no benefit. Some patients functionally wound up with too many of that kind of neuron, and so then you have an imbalance in how those neurons talk to all the other connections in the brain. And now with deep brain stimulation working so well in very sick Parkinson's patients, I think the Michael J. Fox Foundation, for example, is not funding heavily stem cell research into Parkinson's. But other people are working on it. In the Alzheimer's space, this is a place where the induced pluripotent stem cells are really going to play a role in drug development. So Larry Goldstein, who's the head of the UCSD Stem Cell Group has developed a beautiful disease in a dish model for Alzheimer's by taking cells from Alzheimer's patients and making iPS cells and then growing them into neurons and finding the abnormalities in their response to insult and how they accumulate these abnormal proteins. And that will be a great basis for screening for drugs for Alzheimer's. So stem cell biology will have a reach-in, not by regenerative therapies, but by these screening models. Yeah. Thank you so much.
I'd like to thank Dr. Csete for taking time out of her very, very busy schedule. I think you said you're off to Brazil next, I think. So we really appreciate you coming to St. Louis and presenting this important information. I would like to thank all of you for your support and coming out for our speaker series. And I forgot to mention that our speaker series is sponsored by the Steinberg Family Foundation, and I can announce that they're also sponsoring our 2013 speaker series. So I would encourage you, we'll get an email out to all of you. You'll know when our next speaker is. We are redesigning our website at the end of the year. We'll have a lot of great information. We're going to have individual disease pages, the advances that's going on in that particular area. So again, thank you so much for coming out and supporting us today. Appreciate it.